Hello, and welcome to the first video in the Introduction to Medical Nutrition Therapy series. Today we'll be introducing to you enteral nutrition. By the end of this section on enteral nutrition, you will be able to define enteral nutrition, describe why EN is used and what setting it will be used in, discuss the different routes by which EN can be delivered, discuss the characteristics of feeding tubes, and compare and contrast different enteral feeding formulas. So what is enteral nutrition and why is it used? By definition, enteral nutrition refers to providing nutrition directly into the gastrointestinal tract, bypassing the oral cavity. Another common term used to reference EN is tube feeding. Why is enteral nutrition used? EN is used when nutritional requirements cannot be met through oral intake, whether it is because an individual cannot consume foods orally due to a variety of different conditions that will be discussed in part 2 of this video series, or when an individual cannot consume enough nutrition to support their needs. EN can be used as a sole source of nutrition or as supplemental nutrition, meaning it can be given alongside other forms of nutrition to ensure an individual is receiving all of their nutritional requirements. EN can be used in most care settings, including but not limited to critical or acute care, rehabilitation, long-term care, and at home. As you can see here on the picture, individuals on EN can live healthy and active lives.
Let's discuss the routes of enteral nutrition. An enteral feeding tube can be inserted through the nose or mouth or through incisions in the abdomen, where the end of the tube will sit in the stomach or the jejunum. This diagram provides an overview of the different sites a feeding tube can be inserted and the different parts of the digestive tract that the tube will terminate. Let us first focus on feeding tubes inserted in the nose and less commonly the mouth. NG tubes go in through the nose and end in the stomach, whereas ND and NJ tubes also enter through the nose, but they are progressed further into the digestive tract, where the end of the tube sits in the small bowel. There are some instances, such as when a critically ill patient is intubated and on a ventilator, that the tube is inserted into the mouth and terminates in the stomach. This is referred to as an OG tube, but is less common. Here are some examples of feeding tubes that have been inserted into the nose. Nasal routes are typically used for shorter periods of time, such as a few weeks. However, they can remain for longer periods depending on the case. Now we will talk more in detail about the routes of enteral nutrition in which the tube is inserted directly into the stomach or small intestine. Gastrostomy and jejunostomy tubes are both inserted through incisions made in the abdomen. However, a gastrostomy tube is inserted directly into the stomach and the end of the tube sits in the stomach. In contrast, a jejunostomy tube is inserted directly into the jejunum, which is also where the end of the tube will sit. On the other hand, we have the GJ tube that is inserted directly into the stomach, but then is progressed through the stomach and sits in the jejunum. Here are some photos of individuals with a gastrostomy and jejunostomy tube, which are commonly known as G tubes and J tubes. These types of tubes are typically used for longer periods of time. There are 3 methods that are used to place tubes through the abdomen: endoscopy, radiology, and surgery. Endoscopy uses an endoscope to guide the placement, radiology uses an X-ray, and tubes can also be surgically placed. Here's an X-ray view of how a G-tube looks when it's placed. Here are the names of each procedure. Nomenclature for GJ tubes also follow this naming pattern. Depending on the method of placement, Feeding tubes are typically placed by physicians, nurses, intervention radiologists, or surgeons. Doctors and nurses can insert feeding tubes at bedside if they're trained.
Feeding tubes are typically made out of polyurethane or silicone. Polyurethane material is less comfortable, more stiff, and a thinner tube, and is used for nasoenteric tubes. Silicone material is more comfortable, less stiff, and a thicker tube, and is used for abdominal feedings. The ports are where a connector can be used to deliver the feed and/or medication through the feeding tube. The feeding tube is the length of the tube, and small bowel terminations are longer and stomach termination tubes are shorter. The disc secures the tube on the abdominal wall to prevent movement of tube. The balloon is a part of the tube that sits against the stomach wall to prevent dislodgement. Here is an example of the feeding tube inserted into the stomach. As you can see, the disc sits against the abdominal wall and the balloon sits against the stomach wall. Ports are used for gastric feeding, medication delivery, or balloon inflation. There are Y ports or single ports for nasoenteric feeding tubes. Y ports have two openings, one for feeding and one for medication or irrigation. The photo on the slide is an example of a Y port. A single port is just for feeding. All ports and connectors used for enteral feeding are purple. Feeding tubes come in different sizes. Tubes are measured in French units. 1 French unit equals 0.33 millimeters. Small bore tubes are 5 to 12 French units and are more comfortable and easier to place into the small bowel. Large bores are larger than 14 French units. As you can see, 24 French units is about the size of a penny. Enteral feeding can be administered via various schedules that I will discuss in the following slides. Before we talk about feeding schedules, it should be noted that enteral feeding can be administered via a pump or by gravity. Pump-assisted feeding is when the feeding tube is attached to a feeding pump. This allows you to set the amount of feed given over a predetermined time. The gravity drip method is when no pump is used to administer feed and the feeding bag is hung on a pole, and the rate is controlled by a roller clamp. Gravity and pump-assisted are the two methods used to deliver feed. Continuous feeding is when feed is given at a consistent hourly rate for 24 hours a day. Cyclic feeding is administered over a shorter period of time, usually 4 to 8 hours, at a consistent hourly rate. This improves quality of life for patients with less time being spent on the feeding pump. The little sleeping emojis do not necessarily mean the patient is sleeping. It just means that this is a time that the patient does not have to have feed being administered. Intermittent feeding provides large volumes of feed into the stomach over shorter periods. It is administered for 20 to 60 minutes with a volume of 1 to 3 cups and typically is done 4 to 6 times per day. This will follow meals and snack time schedules. Bolus feeding is administered via a feeding syringe with a set volume over a shorter time period. It is administered 3 to 8 times a day. 200 to 400 milliliters are provided over 15 to 20 minutes. This mimics normal meals and gives freedom of movement for the patient. This is an example of someone with a feeding tube who is bolus feeding, which, as you can see, allows for much more freedom. Enteral nutrition can be delivered by nurses or by the patient or family.
Now that we know what enteral nutrition is, why it is used, and how it is administered, it's time to take a look at what goes through the tubes, enteral formula. As you can see on this slide, there are many different types of formulas. The most common type is a standard formula that mimics a general diet. These formulas have varying amounts of energy, protein, and other nutrients seen on the slide. They are usually lactose and gluten-free. Standard formulas meet the nutrition needs of most patients on EN support. Next are blenderized formulas. These are blended foods typically administered via bolus feeding. These can be given alone or with standard formula. Blenderized formulas can be homemade or purchased as commercial products. These allow the feeding tube to be a second mouth instead of a medical necessity. You may also encounter modified formulas for specific conditions such as malabsorptive disorders, diabetes, or chronic kidney disease. These formulas may have nutrients broken down for easier absorption or may be modified such that a formula for someone with diabetes has less sugar, or one for an individual with kidney disease is lower in potassium and phosphorus. Lastly, single nutrient products may be added to EN formula to meet nutrition needs. These are called modulars. Common modulars are protein and fiber. It is important to note that powder formulas are dissolved in water and administered via syringe. They are not mixed into formula. The provision of EN support is a multidisciplinary process. Physicians and nurses can place feeding tubes, sometimes even at the bedside. Dietitians are in charge of the EN prescription, nurses administer the formula, and monitoring is done by dietitians, physicians, and nurses.
In summary, enteral nutrition or tube feeding is used when an individual cannot eat orally or is unable to consume adequate nutrition by mouth. EN can be used to provide sole source or supplemental nutrition. Feeding tubes can be inserted into the nose, mouth, stomach, or jejunum and terminate in the stomach or jejunum. EN ports and connectors are purple. Feeds can be administered using gravity or pumps at different time intervals. There are many types of formulas and modulars used to meet an individual's nutrition needs. The delivery of EN therapy requires a multidisciplinary team. Stay tuned for part 2 of our 4-part series on enteral nutrition, indications and contraindications for enteral nutrition.
Welcome to part 2 of the Introduction to Medical Nutrition Therapy Enteral Nutrition video series. In this video, we will be discussing the indications and contraindications for enteral nutrition therapy. By the end of this section, you will be able to state where digestion and absorption of nutrients occurs along the GI tract and when the use of enteral nutrition therapy is indicated and contraindicated. When a person eats, typically food is ingested through the mouth, swallowed, and then travels through the esophagus, stomach, small intestine, and large intestine. The digestion or breakdown of food occurs largely in the stomach and in the small intestine by means of physical and enzymatic breakdown. After being broken down, the vast majority of absorption, or the body's uptake of macronutrients, vitamins, and minerals from food, occurs in the small intestine. From there, what remains is passed into the large intestine, where water and electrolytes are reabsorbed. It should be noted that the large intestine cannot absorb macronutrients, or carbohydrates, protein, and fat, or vitamins and minerals. After traveling through the large intestine, remaining content is excreted from the body as fecal matter. There is a general rule in medical nutrition therapy: if the gut works, use it. This is to say that if the GI tract functions properly as we described in the previous slide, we as healthcare providers want to ensure that the nutritional therapies we prescribe maintain the GI function. There are some cases where the gut is not functioning and other means of nutrition may be warranted, such as nutrition through an IV, which we will learn about in our next medical nutrition therapy series.
When would we use enteral nutrition, which we will refer to as EN? Generally, the two primary indicators to start a patient on EN are the inability to consume foods orally or the inability to consume an adequate amount of food and fluids through an oral diet. Factors preventing individuals from consuming foods orally include dysphagia, decreased level of consciousness, such as when someone is heavily sedated, being intubated and ventilated, and mechanical obstructions in the proximal GI tract. In contrast, individuals may be able to consume foods orally, but not enough for them to maintain adequate nutrition. This can happen in the setting of poor appetite or due to side effects relating to various treatments or therapies. Some of these factors we will discuss further. Issues relating to oral function relate to issues concerning the mouth, which, of course, is the site for food entry and the starting point for oral food intake. Dysphagia, the medical condition relating to decreased or loss of swallowing function, can greatly impair a patient's ability to ingest food by mouth. This condition is commonly seen in individuals who have had a stroke or neurological impairment impacting swallowing function. Thus, EN should be considered to ensure they receive adequate nutrition. We may have patients with decreased level of consciousness and alertness, such as those who are heavily sedated, which precludes one's ability to eat orally. Critically ill patients who are intubated with an endotracheal tube are typically sedated and have decreased level of consciousness. However, they also cannot consume food orally due to the presence of the endotracheal tube in the mouth. Thus, initiation of EN therapy is warranted. Low level of consciousness and alertness can also be associated with patients in critical care where we may see ventilation and intubation. With the use of ventilation and intubation, ingesting food by mouth is not practical, as an endotracheal tube for ventilation will be sitting in our patient's mouth for most of the time. Therefore, the mouth area for our patients are occupied at the moment, and this is one of the indicators that we want to start EN. Some individuals may have an obstruction along the GI tract, preventing foods that are consumed from moving through our GI tract. If it is a complete obstruction, the individual will not be able to safely eat. As we previously introduced, a functioning GI tract is essential for the uptake of nutrients. If we have a blockage from a tumor at the red X here in the middle of esophagus, food cannot travel to the stomach for digestion. Blockage can also take place proximal to our digestion and absorption site. For example, the red X here on the stomach indicated a blockage, and this can impair the ability for our patient to digest and absorb food. If patients have obstructions proximal to the site of digestion and absorption of nutrients, they can still be fed by enteral nutrition distal to the blockage. For example, for the individual with the obstruction in the esophagus, a gastrostomy feed tube, which you learned about in previous video, could be placed. The second overarching reason we might want to consider using EN is for individuals with insufficient calorie and nutrient intake due to the side effects of illnesses or treatments. For example, patients who are of advanced age, patients with chronic diseases, or patients with advanced cancer can experience poor appetite, which is referred to as anorexia. This can be associated with the pathophysiology of their diseases. Additionally, medical and surgical treatment of some conditions, such as chemotherapy or radiation therapy, can result in side effects that negatively impact the ability to eat enough, such as pain with eating or swallowing.
As we've mentioned, our goal is to always use the GI tract whenever possible. EN allows the GI to continue to work, which plays a large part in both maintaining GI integrity and immune function. However, there are circumstances in which EN would not be appropriate. Listed here are some of the broad categories of contraindications, which include impairment along the GI tract or intestinal obstructions. Impairments mean that nutrients are not able to be absorbed, and obstructions are when feeding cannot occur distally to set up suction. The bottom line is that the primary reason to not use EN would be a non-functional GI tract. One thing that is not listed on the slide is that at the end of life, EN could be a contraindication based off of the aggressiveness of the medical nutrition therapy. The decision to provide EN therapy to someone at end of life is made on a case-by-case basis and takes into consideration the patient's medical status, as well as the patient and/or family's preferences and values. Examples of conditions associated with nutrient and fluid malabsorption include short bowel syndrome enterocutaneous fistulas, and vomiting/diarrhea. For short bowel syndrome, as seen by the name, this is when the short bowel has been shortened due to a resection resulting in malabsorption. In essence, the small intestine is much shorter than normal in both length and function. When seeing if EN is appropriate or not, it's important to look at the section of the small bowel that still has capability to see the extent to which absorption can occur. Since nutrients are absorbed in the small intestine, EN could be a contraindication if adequate nutrient absorption is not able to occur, and therefore other routes of feeding would be considered. This includes feeding through an IV, which is called parenteral nutrition, which will be discussed in the next medical nutrition therapy video series. A fistula is defined as an abnormal connection between two organs, skin, or a wound. This can occur in the GI, often due to surgery, and is called an enterocutaneous fistula. Depending on the fistula origin, there can be malabsorption. One reason a fistula would be contraindicated for EN is if there is a fistula in the small bowel. Since there is no nutrient absorption in the large bowel, EN would not be an option, as we would not be able to feed distal to this fistula. In addition, avoiding EN decreases the output of the fistula, allowing it to heal. In this case, other routes of feeding would be considered, such as PN, as this decreases the chance of malnutrition, loss of fluid and electrolytes, and potential chance of sepsis. As we know, nutrition status plays a large part in overall healing and overall mortality rate. Extremely severe vomiting or diarrhea are also examples of other contraindications, as absorption of nutrients administered into the GI tract cannot occur in this context. And lastly, with a bowel obstruction, the body's ability to absorb nutrients or clear stool from the body can become impaired. Depending on the location and the size of said obstruction, EN can be contraindicated. In this picture, we've drawn a red X that symbolizes a blockage at the start of the large intestine. In this case, we can't feed distal to this obstruction because that would mean feeding into the colon where, as we previously outlined, no nutrient absorption occurs. Thus, EN would not be appropriate in this instance.
This brings us to our case study. Our patient is Jonathan Doe. He is a critically ill patient admitted to the ICU in Saskatoon. He has respiratory failure requiring intubation and ventilation. He also has acute renal failure requiring continuous renal replacement therapy. He does have a functional GI tract with no evidence of malabsorption. Based on what we discussed today, enteral nutrition is indicated for Jonathan. In summary, we discussed that nutrient digestion and absorption occur mainly in the stomach and small intestine, that indications to start EN therapy relate to being unable to eat orally or having an insufficient oral intake, and that primary contraindications for EN include malabsorptive disorders and intestinal obstructions. This is the end of Enteral Nutrition Part 2. Thank you for listening and stay tuned for Part 3, a registered dietitian's role in the delivery of enteral nutrition.
Hello, and welcome to Part 3 of the video series on Introduction to Medical Nutrition Therapy, Enteral Nutrition. In this video, we will present to you the registered dietitian's role in the delivery of enteral nutrition. By the end of this section on enteral nutrition, you will be able to state the registered dietitian's role in the delivery of enteral nutrition therapy, describe the factors that must be taken into consideration when prescribing and administering enteral nutrition, define refeeding syndrome and state the four-pronged approach to mitigating the risk of someone developing refeeding syndrome, and state the four main components of an EN prescription. The primary role the RD plays in the delivery of enteral nutrition is to determine the patient's EN prescription, which we determine by completing a thorough nutritional assessment, which includes the determination of the patient's specific nutritional requirements. To do so, we first estimate the patient's calorie requirements, which is done by referring to condition-specific clinical practice guidelines, or, in their absence, validated equations. Next, we determine their macronutrient and micronutrient needs, also based on the individual's disease state or condition. Macronutrients include carbohydrate, protein, and fat, whereas micronutrients include vitamins and minerals. Part of the RD's role is to identify and treat or prevent macro and micronutrient deficiencies based on biochemical and physical assessments. Supplementation may or may not be required and is assessed on a per-patient basis. Lastly, we consider a patient's fluid requirements, which largely depends on the patient's fluid status. These parameters help us to determine the patient's enteral nutrition prescription to be administered. The key components of our prescription include which formula the patient will be given, how much formula they will be given, and the rate at which the formula will be delivered. In order to determine a patient's EN prescription, the RD first performs a nutrition assessment, which has several components as you can see here. Factors such as the patient's age, their weight and BMI, as well as muscle and fat stores, any laboratory or medical tests they've had or are upcoming, indicators of fluid status, and medications are all necessary pieces of information we require in order for us to determine a patient's optimal nutrition prescription. So, how does a dietitian determine a patient's calorie, macronutrient, and fluid requirements? In many cases, we refer to disease or condition-specific clinical practice guidelines that have been published to guide the nutrition management of individuals with these conditions. All of the data we collect in our assessment helps us to determine which guidelines to follow and to estimate the patient's calorie, nutrition, and fluid requirements. For example, we have guidelines for providing nutrition therapy in critically ill patients, surgical patients, and those with polymorbid chronic conditions. Individuals may need additional vitamin and mineral supplementation. How much is dependent on the patient's medical condition, findings from our nutrition assessment, such as the physical assessment, in which we look for identifying features of specific micronutrient deficiencies, and by examining blood work. For example, serum B12 and 25-hydroxyvitamin D can help us determine vitamin D deficiencies and B12 respectively. With respect to determining how much fluid a patient will require, there are several factors we must consider. While validated equations and clinical practice guidelines often provide recommendations to guide in the estimation of a patient's daily fluid requirements, other factors that will influence our final recommendation include the patient's condition, their fluid balance, and sometimes a physician will determine what a patient's total fluid intake should be. It is important to note that enteral nutrition therapy can provide a patient with all of their fluid needs. So if a patient is on IV fluids to maintain their hydration status prior to starting enteral nutrition, once the EN has been initiated, the IV can be decreased to a rate to keep the vein open or discontinued entirely. It is important for the dietitian to review a patient's lab values, examples of which you can see on this slide, before EN is initiated. Analyzing these values can help identify deficiencies, inflammation, disease severity, as well as an insight into overall health and well-being. Labs help inform our choice of enteral feeding formula and are an important part of monitoring enteral feeding tolerance, as you will learn more about in the next video of our EN video series.
Medications typically consumed orally can be crushed and mixed with sterile water and then administered through a feeding tube. Absorption of some medications may be reduced when administered with EN. Some examples of these medications include Dilantin, commonly used to manage seizures, the fluoroquinolone class of antibiotics, and levothyroxine, used to treat hypothyroidism. However, dietitians can adjust the schedule of EN based on a patient's medications to mitigate the risk of drug-nutrient interactions. RDs also collaborate with other health professionals, such as nurses, pharmacists, and physicians, regarding drug-nutrient interaction to ensure that care provided is safe and effective. There are other important factors we consider when determining the patient's EN prescription, which include the site where the feeding tube has been inserted, for example, through the nose, and whether the feeding tube terminates in the stomach or the proximal small intestine. Other considerations include whether a patient has any food allergies and the mitigation of possible complications associated with EN. which might include fluid overload and refeeding syndrome, which we will review in the next slides. Refeeding syndrome is a severe disruption in electrolyte and fluid balance that is precipitated in malnourished subjects when feeding is begun too aggressively after a period of inadequate nutrition. Patients who were previously well nourished but have been admitted to hospital with severe metabolic stress are also at high risk. As you can see in the diagram on the right, there are a series of metabolic reactions that occur when a starved patient is fed too quickly. In brief, after the initial start of nutritional intake in patients in such a starved or catabolic state, glucose concentration and insulin secretion rises suddenly, leading to an overwhelming shift in electrolytes with increased sodium and water retention and extracellular volume expansion. The potential clinical consequences are volume overload with risk for heart failure and peripheral edema, as well as transcellular shift and redistribution of phosphate, potassium, and magnesium that are associated with life-threatening complications such as cardiac arrhythmias. Additionally, the hypophosphatemia may result in possible muscle weakness. In the worst-case scenario, if a patient is fed too aggressively and the signs and symptoms of refeeding are not addressed, death can occur. In addition to malnutrition, chronic and acute starvation, there are other conditions that increase a patient's risk of developing refeeding syndrome, which include patients who have recently undergone bariatric surgery, those with aggressive malignancies, chronic alcohol use, eating disorders, recent intestinal surgery, and conditions associated with nutrition malabsorption. Fortunately, refeeding syndrome can easily be prevented, but it requires a coordinated effort from the multidisciplinary team. To do so requires a four-pronged approach. First, the team must identify whether a patient is at risk of refeeding syndrome, as per the general criteria we previously outlined. If it is determined that the patient is at risk, then the following actions must be taken prior to and during the initiation of nutrition support, whether it be enteral, parenteral, or even an oral diet. Fluid balance needs to be assessed to determine the patient's fluid requirements to ensure that fluid overload is avoided. Blood work, including making sure that potassium, phosphorus, and magnesium are ordered, must be done before nutrition support is started and subsequently corrected for via IV or oral supplementation. The latter if the patient can safely swallow oral medications or if the feeding tube is in sight. Due to the metabolic nature of refeeding syndrome, thiamine could be depleted, so the patient might be an appropriate candidate for short-term thiamine supplementation as well. It should be noted that these electrolytes do need to be corrected before feeding is initiated and can happen concurrently with the initiation of nutrition support. From a nutrition perspective, the dietitian will determine what the patient's target nutritional requirements are. However, one of the most crucial aspects of reducing the risk of refeeding syndrome occurring is to start EN slowly, meaning providing a volume of formula that might be as low as 20% of their estimated calorie target. The higher the risk of refeeding a patient is, and this is easily determined by a dietitian, the lower the amount of calories that will be given. On the other hand, if a patient is not deemed at risk for refeeding syndrome, enteral feeding can be initiated as per standard protocols, as per the RD recommendation.
Now, we are going to take you through an example of how a dietitian will determine an EN prescription in a critically ill patient. We will start with a recall of our patient, Jonathan Doe. The patient is critically ill and was admitted in the ICU in respiratory failure and acute renal failure, requiring continuous renal replacement therapy. Enteral nutrition therapy is indicated, and this dietitian has been consulted by the physician or by self-referral to determine the EN prescription. Based on our nutritional assessment, we have determined that the patient is also at a high risk for developing refeeding syndrome. Our most recent critical care guidelines suggest the patient receive between 12 to 25 calories per kilogram body weight per day and up to 2.5 grams of protein per kilogram body weight. As you can see, These are pretty wide ranges, and the dietitian determines the final prescription based on their nutritional assessment and clinical judgment. In this case, after calculating Jonathan's requirements, we determined that the best enteral formula for him was one called Promote, as seen here, and then subsequently determine the volume of Promote he needs and the rate which we will prescribe. This is the final prescription, also called the goal rate for our patient. Promote at 75 ml per hour for 24-hour continuous with 50 ml water flushes Q4H. Looking into the prescription component separately, we can see that dietitians indicate first the formula type that is best suited for the patient. This is followed by the rate that formula is to be infused by the feeding pump, which is based on the total volume of formula we determined was required to meet his nutritional requirements. As our patient is critically ill, it is common practice to start with a continuous feeding schedule, which is stated after the rate. Lastly, we state the volume of water that should be flushed into the feeding tube that is determined by the patient's fluid requirements. It should be noted that to maintain the patency of the tube and reduce the risk of the tube clogging, at minimum, tubes must be flushed with 30 ml of water every 4 hours. Since the patient is at a high risk for refeeding syndrome, we will start our prescription at a lower rate, as shown here, and progress the rate to goal based on monitoring, which you will learn more about in the next video. In summary, dietitians in collaboration with the multidisciplinary team have an essential role in the delivery of EN therapy, specifically as it relates to determine the EN prescription, which is informed by our comprehensive nutritional assessments and nutritional clinical practice guidelines. When an individual is first started on enteral nutrition, we must assess their risk of refeeding syndrome, which is a potentially fatal but preventable through a coordinated multidisciplinary approach. Lastly, when the EN prescription has been formulated, it is written in a format that includes the formula, the rate is to be infused, the feeding schedule, and volume of water flushes. Up next, we have the part 4 of our 4-part series on enteral nutrition, monitoring enteral nutrition. Thank you very much for watching our presentation.
Hello and welcome to Introduction to Medical Nutrition Therapy, Enteral Nutrition Part 4. This is a continuation of our education series on enteral nutrition therapy. You have previously learned about what is EN, indications and contraindications for EN, and formulating an EN prescription. We will now discuss monitoring of enteral nutrition therapy after it's been initiated. By the end of this section on enteral nutrition, you will be able to state the 3 broad domains of monitoring EN therapy, define gastric residual volume and how this measurement is employed in the delivery of EN, identify the most common complications that may occur during EN therapy, describe monitoring for and the management of refeeding syndrome, describe the strategies that can be employed to reduce the risk of EN-associated complications, and describe strategies that can be employed to treat or manage common complications associated with EN. We want to refamiliarize you with our case study patient, Jonathan Doe, and emphasize that EN therapy is a multidisciplinary therapy. Mr. Doe had an NG tube successfully inserted by a physician at the bedside, as seen here. The dietitian has come up with a prescription, the key components of which are the type of formula, how much formula will be provided, and the rate at which the formula will infuse via the feeding pump. The nurse will administer the formula, which includes putting the formula into the bag and setting the rate on the pump, as you can see being done here. Now that EN has been initiated, it is important we monitor gastrointestinal tolerance, identify and manage any complications that arise, and evaluate the effectiveness of therapy.
Monitoring EN therapy broadly encompasses 3 domains. The first domain relates to the assessment of gastrointestinal tolerance to EN. For example, does the patient appear to have concerns related to gastric motility, or are they experiencing other signs of GI intolerance?
It should be noted that some symptoms that appear to be intolerance to EN therapy may be caused by another source. For example, antibiotic therapy can also cause diarrhea. If the cause is determined to be associated with EN, the dietitian can make adjustments to the EN regimen, whereas other symptoms related to intolerance might be better managed by medical therapies such as medication administration, which we will discuss in further detail later in this presentation. Simultaneously, we also want to identify and manage non-GI related complications that can be associated with EN. These complications can broadly be grouped into the following categories: metabolic, pulmonary, hydration, and tube-related, each of which we will also discuss in more detail. Lastly, as with any therapy, we engage in ongoing monitoring to evaluate the effectiveness of this type of nutrition therapy, which primarily relates to ongoing reassessment of the patient's nutritional status. Let us look further into the first domain on EN monitoring, which is the assessment of GI tolerance. Assessment of GI tolerance to EN involves a physical exam to identify signs of GI tolerance such as pain, abdominal distension, or a hypoactive bowel in which gas or stool is not passed for several days. GI symptoms that may be indicative to poor tolerance to EN include delayed gastric emptying, nausea, vomiting, diarrhea, and constipation. One of the many causes of feeding intolerance relates to slowed or delayed gastric emptying. One strategy to assess gastric emptying is measuring gastric residual volume, which is the volume of fluid remaining in the stomach at any point in time. This is typically done by a nurse who aspirates gastric contents of the stomach using a syringe. In theory, if an individual has high GRVs, then they may be at a higher risk of aspiration. However, it should be noted that measuring GRVs is highly controversial as there are many factors that can influence this measurement, and studies have been inconsistent in demonstrating the association between high GRVs and aspiration. What is considered to be a high GRV is also widely debated, with recommendations ranging from 250 to 500 milliliters. However, it is important to note that most hospitals have a standardized protocol and procedure in place regarding the measurement of GRVs, and healthcare practitioners must make themselves aware of these protocols. Here we have outlined a simplified example of a GRV assessment protocol. GRVs are typically measured every 4 hours for the first 48 hours after EN is initiated. If the volume of the GRV is less than 500 milliliters, the threshold we have set for this example, then the volume of the stomach contents aspirated is refed via the syringe and EN continues as prescribed. Conversely, if the GRV is greater than 500 milliliters, 400 milliliters of the GRV should be refed and the EN infusion should be held for 1 hour. Upon rechecking the GRV, if it is now under 500 milliliters, feeds can continue as prescribed. And if it remains over 500 milliliters, the EN infusion should be continued, but at a decreased rate between 20 to 25 milliliters per hour, and a prokinetic agent should be started. If the prokinetic agent fails, the nasogastric feeding tube should be removed and a nasoduodenal or nasojejunal feeding tube inserted in its place.
If a patient is experiencing nausea or vomiting, there are a number of potential causes that could be considered, the most common related to EN, of which we will discuss. First, nausea and vomiting can occur secondary to delayed gastric emptying, which can occur in a variety of medical conditions such as diabetic gastroparesis or sepsis, or secondary to medications. In addition to the use of prokinetic agents, as just discussed, other treatments to manage delayed gastric emptying include changing the formula, using room temperature formula, or reducing or discontinuing narcotics. Second, nausea and vomiting may also be a result of poor tolerance to the chosen enteral formula or delivery rate and modality. Thus, management strategies also include changing the EN formula and making sure it is at room temperature, reducing the infusion rate if the patient is receiving EN via a pump, or if they are receiving bolus feeds. We could switch to a continuous feed. For individuals who continue to experience nausea despite attempts to manage it, antiemetic medications should be prescribed. When a patient presents with diarrhea or constipation similar to nausea and vomiting, this can be due to the EN prescription itself, but can also be related to other factors such as disease or medications. Conditions associated with diarrhea include bacterial infections or primary GI conditions such as inflammatory bowel disease. Conversely, dehydration and irritable bowel syndrome are associated with constipation. As you can see here, a variety of medications are associated with diarrhea and constipation. There are just some examples, and it is not a comprehensive list. For all of these conditions, the enteral nutrition prescription can be modified by changing the type of formula, the infusion rate, or the amount of free water provided. It is important to note that in absence of treating the condition or reassessing medications, diarrhea or constipation could persist. It must be acknowledged that fluid and electrolyte status are often related to GI symptoms, with vomiting and diarrhea resulting in excess fluid losses, whereas constipation may be associated with inadequate fluid intake. Thus, the volume of fluid delivered by both IV and nutrition support should be adjusted as appropriate to help maintain a patient's fluid balance.
If we come back to Jonathan Doe, he was started on EN. During our routine monitoring, we identified that he was experiencing persistent diarrhea. He did not appear to be on any medication or any conditions that are associated with diarrhea. Therefore, adjusting his EN prescription was warranted. In this case, we transitioned him to a semi-elemental formula with lower osmolality. This type of formula contains partially digested nutrients and is thus easier to absorb. We maintained him on a continuous infusion. After this transition, his diarrhea resolved. The next broad domain associated with EN monitoring relates to the identification and management of some common complications that can occur secondary to EN therapy. Typically, complications associated with EN can be grouped into the following categories: GI, which we just reviewed, metabolic, pulmonary, hydration, and tube-related complications. One of the key parameters we use to monitor EN therapy is blood work. It is quite common for hospitals to have standardized enteral nutrition order sets that include orders for routine blood work following the initiation of EN. This is an example of the standardized order sets for adults that is used in Saskatoon hospitals. As you can see, routine blood work denoted here as total enteral nutrition is part of the order set. This is the TEN blood work protocol. On the top row, the numbers represent the day after EN is initiated. The first column represents which labs are taken, including chemistry, a CBC, and renal and liver panels. 24-hour urinary nitrogen is also measured, as this can give the dietitian an indication as to whether a patient is receiving adequate protein.
Metabolic complications can arise after EN is initiated, which may be associated with EN itself or related to medical conditions. Metabolic complications relate mainly to shifts in electrolytes, hydration status, or glycemic control. As you learned in part 3 of this video series on EN, refeeding syndrome is also a concern when EN is first initiated. Recall that refeeding syndrome is the severe disruption in electrolyte and fluid balance that can occur when feeding has begun too aggressively after a period of inadequate nutrition. As you can see in the diagram on the left, there are a series of metabolic reactions that occur when a starved patient is fed too quickly. In brief, after the initial start of nutritional intake in patients in such a starved or catabolic state, glucose concentration and insulin secretion rises suddenly, leading to an overwhelming shift in electrolytes with increased sodium and water retention and extracellular volume expansion. The potential clinical consequences are volume overload with a risk for heart failure and peripheral edema, as well as a transcellular shift and redistribution of phosphate, potassium, and magnesium that are associated with life-threatening complications such as cardiac arrhythmias. Thus, in monitoring for refeeding syndrome, we pay particular attention to potassium, phosphorus, and magnesium, as they can fall well below normal ranges, as well as for signs and symptoms of fluid overload and cardiac function. As you learned in video 3 of this series, the best way to manage refeeding syndrome is to prevent it in the first place. However, in the event that refeeding syndrome is occurring, it can also be managed. When EN is initiated, if there are no signs or symptoms of refeeding syndrome, no modification to the EN therapy is required. In contrast, if a patient is showing signs and symptoms of refeeding, which is identified by monitoring the parameters listed, the following treatment strategies are suggested. A zero fluid balance must be maintained, which may require adjusting fluid from IV or EN. Electrolytes should be corrected by supplementation as necessary, and patients should also be supplemented with thiamine and a multivitamin or mineral, as thiamine is typically depleted if refeeding occurs. Cardiac function must be monitored regularly, and the nutrition prescription must be modified, such as reducing the rate of the EN infusion if it is started too high, and ensuring minimal fluid is given to maintain a zero fluid balance. As you can see, the management of refeeding syndrome is a multidisciplinary effort that requires a coordinated response from the multidisciplinary team.
If you remember from the third video of this video series, Jonathan Doe was determined to be at high risk for refeeding syndrome, and while his goal rate for EN infusion was determined to be 75 milliliters per hour, he was started at 15 milliliters per hour to reduce his risk of developing refeeding syndrome. The day after EN was initiated, in reviewing his labs, all were within normal limits. He was not experiencing signs or symptoms of fluid overload, and cardiac function was normal. Thus, he was safe to have his EN infusion increased. In this case, we increased it by 15 milliliters per hour every 8 hours, continuing to monitor until he reached his goal rate.
The next class of complications is pulmonary. We are typically concerned with risk of aspiration and the development of aspiration pneumonia. The greatest risk factors for pulmonary aspiration are dysphagia or a low head of bed, such that the patient's bed is level. It is important to know that a patient can aspirate on saliva alone, and it is not always attributable to EN. One of the easiest ways to minimize the risk of aspiration is to ensure that the patient's head of bed is at least 30 degrees. Coming back to the standard EN order form used in the Saskatoon Health Region, as you can see in the box, it is standard protocol for a patient's head of bed to be at least 30 degrees. The protocol also outlines the steps for nursing staff to follow in the event. Keeping the head of bed is contraindicated.
We noticed that Jonathan Doe's head was at the same height as the rest of his body and that he appeared to be laying flat. While all members of the multidisciplinary team participate in the identification of risk factors for adverse events, it is important to ensure that the team members who are responsible for caring for the patient are notified. In this case, we notified the nurse on staff that Jonathan was laying flat, and they adjusted his head of bed to 30 degrees.
As briefly mentioned earlier in this video, it is important that a patient's hydration status is monitored when they are receiving nutrition therapies. It is important to remember that fluid shifts are not always due to nutrition, but could be due to the patient's condition or disease state. However, there are many ways in which EN therapy can be modified to help ensure that a patient is in fluid balance. If a patient is in negative fluid balance and it is deemed by the team that they would benefit from additional fluid, a dietitian can increase the amount of free water a patient receives simply by increasing the volume of water flushes given or putting a patient on a lower density formula, which means that the volume of formula required to meet a patient's calorie needs is higher than if they were on a formula that is higher in caloric density. Conversely, if a patient is in a positive fluid balance or overhydrated, we can reduce the volume of water given in each water flush. Of course, remember at least 30 milliliters of water must be flushed through the tube every 4 hours to maintain its patency. We can also choose a higher density formula. It should be noted that if a patient is on IV fluids for hydration purposes, enteral nutrition when infusing at goal rate can provide all of a patient's fluid requirements and the IV can be discontinued.
Complications or side effects related to the enteral feeding tube can also occur. Some common side effects relate to irritation such as an NG tube resulting in irritation of the nasal passages. Infection can also occur such as at the insertion site of percutaneous feeding tubes as shown in the images here. We can have issues related to tube blockages. One risk factor for a tube blocking is failure to flush the tube regularly with water. To prevent this, we need to regularly flush feeding tubes with a minimum of 30 milliliters of water every 4 hours. However, tube blockages can still occur often due to large amounts of crushed medication or protein modulars being delivered through a feeding tube. In the event of a blockage, there are strategies to unblock the tube and restore patency, one of which is the administration of digestive enzymes and sodium bicarbonate. If all else fails, we can change the tube as needed. Coming back to the standard EN order form used in the Saskatoon Health Region, as you can see in the box, there is a standing order for a nurse to use pancreolipase and sodium bicarbonate to clear a blocked tube.
Jonathan Doe's feeding tube was blocked. The nursing staff referred to the EN order sheet and carried out standing order with codazyme and sodium bicarbonate to clear the blocked tube. Once cleared, EN therapy was able to continue. While perhaps not typically associated with the standard gastrointestinal complications, poor oral health is also a very serious complication associated with EN. For individuals who are receiving enteral nutrition as a sole source of nutrition, Because the mouth is not used, there is reduced saliva production, less mechanical cleaning associated with chewing, and often oral care, such as brushing teeth, especially in hospitals, is neglected. Lack of routine care is the #1 cause of oral health-related complications. However, the solution is relatively simple. Provide regular oral care. Encourage family members to bring in a toothbrush and help the patient brush their teeth. Alternatively, nurses can also provide oral care with a family-supplied toothbrush or the hospital-supplied oral swabs.
Perhaps most important when monitoring EN therapy is assessing whether the provision of artificial nutrition is effective and maintaining or improving the patient's nutritional status. What we mean by effective is that we want to ensure that our nutrition therapy is doing what it's supposed to be doing, providing the patient with the necessary calories and nutrients to maintain or improve their nutritional status and to prevent further decline. We use certain parameters to assess nutritional status, which helps us to identify whether someone is malnourished or not. Some of these parameters include weight, muscle, and fat stores, and physical function. We also use a physical assessment as well as labs to monitor a patient's micronutrient and fluid status. If our goals of nutrition care are not being met, and we are not seeing progress in terms of our assessment parameters, there are strategies that can be implemented by the dietitian that include adjusting the EN prescription as appropriate. Conversely, if a patient is maintaining their nutritional status or it has improved in cases where an individual was malnourished to begin with, that is a sign we're on the right track and the EN prescription is effective. It should be noted that monitoring EN is more frequent in the first few days after it is initiated, usually occurring daily. However, as a patient remains on EN for a longer period and is stable, monitoring occurs less frequently. Coming back to the standard EN order form used in the Saskatoon Health Region, as you can see in the highlighted box, there is a standing order for a patient to be weighed, typically by a nurse, but it can also be done safely by a physiotherapist twice per week. Weight is an important indicator used in hospital to monitor the effectiveness of EN therapy over long term, but note it is also a useful measure in identifying fluid shifts.
Coming back to Jonathan Doe, monitoring EN therapy after it was initiated resulted in a number of adjustments needed to be made. First, the routine blood work revealed stable electrolyte status and thus no evidence of refeeding syndrome. Because of this, EN feeds could be increased gradually to goal rate. Second, there were symptoms of diarrhea that appeared to be related to the EN prescription and not other reasons such as medical conditions or medications. After the registered dietitian adjusted the EN prescription by changing the formula, the diarrhea resolved. We also observed that the patient's bed was flat, which is a primary risk factor for aspiration when someone is being tube-fed. The nursing staff was notified and they elevated the head of bed to 30 degrees. No changes to the EN prescription were required. Over the course of his EN therapy, Jonathan's feeding tube blocked. However, his nurse immediately employed the standing order for codazyme and sodium bicarbonate and successfully cleared the tube. EN was restarted again shortly thereafter. After watching this video, you have learned how to monitor GI tolerance after EN has been initiated, identify some metabolic, pulmonary, and tube-related complications associated with EN, how fluid balance can be maintained via the EN prescription, and to reduce the risk of and treat EN-associated complications. This module concludes our series on Introduction to Medical Nutrition Therapy, Enteral Nutrition. For continued education, please see our next series, Introduction to Medical Nutrition Therapy, Parenteral Nutrition. Thank you for watching.